So, hello everyone, and today we'll be discussing the fourth case of this case discussion series. So here we have a 20-year-old male presented with history of seizures and facial port wine stain since childhood. And this is the MRI images of this particular patient. So this is the T2 weighted images, axial section of the brain. So we can see that there is thickening of the calvaria that is seen, and there is some parenchymal loss along with this subcortical T2 hypointensity, linear hypointensity in the subcortical white matter. Then axial section of T1 weighted images. Again, we can see this T1 hypointensity in the subcortical area in the parieto-occipital region along with the thickening of the calvaria, and there is some parenchymal loss. Now this is the T1 post contrast images where we can see that this choroid plexus is a bit enlarged here, and other than that there are some dilated transependymal veins, and there is some leptomeningeal enhancement, abnormal leptomeningeal enhancement that is seen here in this area, and these are the dilated transependymal veins that we can see. Yes. And these are the GRE images, axial section. Again, we can see this blooming, linear areas of blooming, that is the areas which were T1 and T2 hypointense show blooming on GRE, which is suggestive of calcification in the cortical and subcortical region along with parenchymal loss. And then there is dilated transependymal veins as well as the ipsilateral choroid plexus dilatation, and also there is abnormal leptomeningeal enhancement which is suggestive of pial angiomatosis. So hence the diagnosis here is Sturge-Weber. So this was the report that was given by me, that there is some linear subcortical blooming which appears T2 hypointense, which is suggestive of subcortical calcification in the left occipitoparietal region, giving a tramp track sign. So this is a typical tramp track sign, tramp track type of calcification. And then there is associated parenchymal loss along with that calcification, and also there is ipsilateral choroid plexus enlargement. So why there is parenchymal loss also, we'll come to that in the later parts of the slides. And then there is post contrast enhancement of the leptomeninges in that particular area, which is suggestive of pial angiomatosis, and also we could see some dilated transependymal veins, and there was evident left calvarial thickening. So these features were suggestive of Sturge-Weber syndrome. So Sturge-Weber syndrome or encephalotrigeminal angiomatosis, why it's called encephalotrigeminal is because along the trigeminal nerve distribution, especially the ophthalmic division of the trigeminal trigeminal nerve, there is pial and there is cutaneous port wine stain that is seen. So it's actually a phacomatosis which is characterized by facial port wine stain and pial angiomas. So Sturge-Weber syndrome can be classified according to the presence or absence of facial and leptomeningeal angiomas into type 1, type 2 and type 3. Type 1 represents the classic syndrome with both facial and leptomeningeal angiomas, which may have glaucoma as well. That is buphthalmos. In type 2, the facial angiomas without evidence of intracranial disease is present. That is, they may have glaucoma, but there is no intracranial manifestation of the disease. In type 3, there is isolated leptomeningeal angioma with no glaucoma. So on CT, if this patient is taken for a CT scan, or in case of any Sturge-Weber intracranial manifestations on a CT scan, we typically find this tramp track sign, that is cortical and subcortical calcifications associated with parenchymal loss, and calvarial and regional sinus enlargement may also be very evident. There is dilatation of the ipsilateral choroid plexus, which can also be seen in this particular case. And in severe cases, when there is complete atrophy of one hemisphere of the brain, it will lead to Dyke-Davidoff Mason appearance. Then we can also see orbital choroidal hemangiomas, which is also present in Sturge-Weber. and asymmetric cavernous sinus enlargement. On MRI, on T1 post-contrast images, as we could see here, there was prominent leptomeningeal enhancement in the affected area. That is because of the congested internal cerebral veins, a manifestation of pyelangiomatosis, resulting in venous congestive ischemia with infarction and obliteration of cerebral parenchyma. So because of that venous congestive ischemia, there is loss of the brain parenchyma in that particular area. Then other than that, there is enlargement of the ipsilateral choroid plexus, and then there is dilatation of the transependymal veins that communicate between the superficial and the deep venous systems. On GRE sequence, which is sensitive for calcifications, we can find blooming. And on DSA or angiography, in most cases, angiography is abnormal and it demonstrates superficial cortical veins absence with abnormal and enlarged deep venous system.